right. Good afternoon and welcome to the Texas session. This webinar is brought to you by the Center for Substance Use Training and Telementoring, CSTAT. My name is Andrea Havler and I will be your facilitator today. Before we start, I wanted to remind you about some important housekeeping aspects of this session. First off, the session is being recorded and it will be posted at our Be Well Texas YouTube page. For this webinar, we disabled our video and audio capabilities to all participants. However, we have a Q&A box in front of us, and you can use that space to submit your questions. Our speaker will address all your questions at the end of her presentation. You may also use the chat to engage with others or to add any important resources related to the topic today. Again, welcome everybody. Texas sessions are live webinars that we prepare and we put together for all of you in between our Texas Substance Use Symposium conferences to bring to you expert speakers and have important conversations about issues related to substance use disorders at the intersection of policy and practice. The goal of these sessions is to promote awareness, engagement, and support for new projects addressing substance use disorders. So before introducing our wonderful speaker today, I want to make some disclosures, and I want to remind all of you that the views and opinions expressed by the participants and speakers attending the Texas sessions are solely their opinions and do not reflect the official position or policy of the University of Texas at San Antonio. With that being said, I would like to welcome our speaker, Dr. Nidey. Dr. Nidey is a maternal child health epidemiologist. She's an assistant professor at the University of Iowa School of Public Health. She's also a faculty member of the Ohio Perinatal Quality Collaborative. And as the founder of the Empower Project, she's passionate about research and improving health outcomes for persons who use substances and their families. Dr. Nidey, it's a pleasure to have you with you. Thank you for being with us. And whenever you're ready, I think we can start with your presentation.
That's great. Thank you so much for the introduction. And if anytime you can't see my slides or you can't hear me, please make a note in the chat or say something out loud and I'll make sure to fix it.
Absolutely.
Perfect. My name is Dr. Nidey, and today I'm going to talk a lot about the work that I do. We just went over a disclosure slide, so I'm going to skip this. I also have no personal disclosures that I need to share that's relevant for this session. A handful of learning objectives that I have for you today is one, to identify methods to build the capacity of pregnant and postpartum individuals to participate in all phases of research, and to describe how these individuals with lived experience of substance use disorder, including them, would improve the research questions that we're asking as well as our methods. And then to understand the limitations of a one-size-fits-all approach to reducing stigma for pregnant and postpartum folks with substance use disorder. So I'm going to start with an origin story. We care a lot about origin stories in my house. I'm a mom of a couple boys who really love superheroes, so I know too much about origin stories. But I have an origin story for my own research. I like to start my talks off with groups that I've never met before. And so I was working on my dissertation years ago now, and I was getting really frustrated. So my dissertation was focused on substance use. And what that meant is I had to read all of the literature that was written about substance use in pregnancy. And something that I recognized is the way individuals who use drugs were talked about was incredibly stigmatizing. Oftentimes I saw assumptions and then I would follow the citation and find that the original article actually didn't back up that assumption. And as somebody who has some personal history of people that I love who have died from an overdose, I knew that what I was reading wouldn't have kept my friends and family alive. And so I was really frustrated. So this monster right here is an accurate representation of where I was at as I was finishing my PhD. So I decided as soon as I got out of there, and that's the nicest thing to say, because I actually came back here. I'm a faculty member of where I trained. I left and came back a couple of years ago. I said that I'm going to change this and I'm going to start a research program that involves people with lived experience at all phases of the journey to ensure that my work doesn't make other people feel the way that I was feeling at that time. So the Empower Project was founded when I was a postdoctoral fellow at Cincinnati Children's Hospital back in 2019. It was the very first grant that I ever got. It was a small grant from the local CTSA, and I will say it is the most important grant that I have ever gotten, and it changed the whole trajectory of my career. When we first started Empower, we were small. There's just a handful of us from the Ohio area, including Kentucky as well. And then as I got federal funding, mostly from PCORI, I was able to make it a multi-state collaborative. And so to date, there are 20 women who represent 8 different states that are part of Empower. Many of the original 6 women from 2019 are still active members. And our mission changes. We kind of talk about our mission every year. Does this still reflect what we're doing? But it's always kind of around we want to improve outcomes for families with or affected by substance use through patient-centered research and initiatives. This is a picture of myself and some of the Empower moms. We had worked from 2019 on Zoom all the way up until this fall, and I had met all of the moms. I made it, a goal of mine to make sure that I had lunch with everybody in person one time. But the moms coming from different states had never met each other. So this is a picture of women who had worked together for many years. We meet multiple times a week, and we spent a whole week together in an Airbnb in Detroit when we went to the Drug Policy Alliance meeting. So why is this all important? And so hopefully some folks on today's call will also feel this way is that, oftentimes research has been conducted about communities for way too long rather than with them. And what we've seen in research that's separate from mine, so research that is solely focused on looking at the value add, the benefit of including communities and patients, is that we will ask better research questions that actually reflect the needs of the populations we care about versus maybe things that are really scientifically interesting. Those are important, but we also want to think about if our goal is to improve outcomes for people who use drugs, we need to make sure we do research that is going to lead to that end. We'll have better study designs. They become more practical. And if you're not in research, you'll have better like clinical flows or standards of care where things are actually going to work for the people. And then our results are more meaningful as well as actionable, and that our implementation can be more effective and equitable. I really like how a lot of funders now are saying that you need to include communities and people with lived experience. I think there's good ways to do that and bad, but I think it's a good shift to better work in our field. And so most people who know Empower recognize Empower based on all of the things that I have as a journey map. And so this is not my own art, but I am an artist as well. I do different types of art. So I try to bring art into anything I do and to pay artists. So I've had this same artist named Jo. She's from Cleveland. And I've had her do a lot of different things with my team. I'm going to explain this one. This is kind of a weird way that I collected some qualitative data because I was kind of bothered. Usually things I do because I'm bothered by them. I would watch different focus groups and things like that, and there'd be somebody who was writing down what people would say. And I was like, I wonder if they're interpreting what they're saying in the way that it's meant to be interpreted. Did we catch everything that was important and all of the nuances? And how do we know? Because oftentimes, like I teach graduate students, and I'll say something, and somebody will repeat back to me. I'm like, that is not at all what we talked about. And I was like, this has happened, and research it all. And so what I use is this journey mapping approach. So at this time, we had 6 moms in Empower. Each of them met with me one-on-one on Zoom with the artist, myself, and a facilitator who's trained in trauma-informed facilitation. And they were asked to just tell us over a course of 2 hours. So I spent a total of 12 hours in this kind of listening spot. Is what was it like when you found out you were pregnant? And what was it like when you had your baby? Then I had these 6 maps, and then we used qualitative themes to identify the main themes, and we put all of them together into the map that you see here. So this is a visualization of common experiences of the moms that were in the Empower Project. If you are at all interested in using these maps, I have more in your work. You're welcome to email me and I can send you a really nice file to use. But they just do a really great way of when we're talking to people about what is it like to be pregnant and to use drugs, and where are places that we can start addressing some of the problems. I could spend this whole hour talking about this map, but I will leave that there. And again, happy to share and have more conversations about it offline. Then after we did the maps, then we kind of thought about it and stared at the maps together in Empower. And I said, okay, now that we see like these common experiences that everyone it seems to be having in this group, if I got $1 million, which if anybody here has $1 million, I have lots of ideas for it. If we got $1 million in Empower and we can study whatever we wanted, how should we spend that money? So Joe, the artist, again came back. The moms would talk about their ideas, and then Joe would draw this tree and try to make, things kind of make sense when the different tree branches reach out. This was done in the context of COVID. We were not together. And so what I did is after Joe drew the tree, I mailed everybody a colored copy of the map with stickers. And I said, now you can vote for where we need to spend our money. And then because of the PCORI grant that I had already given all of the Empower Moms an iPad. So I knew and also helped with Wi-Fi if it was needed. And so I knew that they were able to take a picture of their map and their stickers with their iPad and email it back to me. And then I took all the maps together and created this one. And what we can really see is where we have most of the pink dots is the interest in changing our understanding of what addiction is, keeping moms and babies together. And on the trunk, you'll see parent-led treatment, and then amplifying voices of lived experience. I think those dots can go together. And so oftentimes if I am like hitting my head against the wall about what should we do next, I look at both of these maps and I see new things in them that I haven't thought about before because I'm really committed to doing work guided by people with lived experience. So after we did all of this together in a meeting, I asked the moms, okay, now we know what your experiences are. We know what you're passionate about. Now what should we do? And the moms, all of them said, we want to learn how to do this work. And when they said this work, what they meant is research, advocacy, writing, giving presentations, telling stories. And this is like kind of a critical moment for a researcher when my time is focused on research. That's how I'm trained. I have different criteria that I have to meet in terms of keeping my job and getting promoted. And there are a lot of things that came out of this that had nothing to do with what I should be doing. But I will argue, and as I had talked to folks that I worked with at the time, is all of these things are going to make my research better and other people's research better and the community better. And this is why we need to support it. So we've done a lot of different things for capacity building for Empower and for the moms in Empower that is directly related to what they said they needed to make a difference. And so the moms wanted to learn how to tell stories, digital storytelling. They didn't use the word dissemination, but they wanted to learn how to share out information. They wanted to be the people who analyze the data and to collect the data. They wanted to be able to interpret the data themselves by looking at the effect estimate and the p-value and the confidence interval to be able to say, this is what it means. They wanted to learn how to design studies and co-develop the things that go with them. They want to have a conference. They want to go to conferences. They didn't use the term critical appraisal. It's a word that we use in epidemiology. I trained my grad students how to like really go through a research article to decide is what is in there actually what they found? Is there bias? Can we believe this? But they wanted to learn how to appraise the literature because they would read research studies that would get kind of flagged in news cycles. And they're like, I don't know how I feel about this and I want to know how to talk about it. And then they also wanted to do website development. So I can share later, but one of the moms is the sole person who manages our website. So that's her job that she has on our project. So some details about some of those capacity building strategies. One is research and dissemination, plus I put advocacy because I think this is also a good example of advocacy. So on our website, we have a link called Reading Between the Lines. And then each month, although we're a little slow to get them up each month, one of the moms will pick a research article that was just talked about in the news, or they heard somebody talk about, or they saw it on social media, or maybe they saw it before, and they want to take time to really kind of dig through it. So then what we do is, because I have a whole group of PhD students who I think need to learn how to do patient engaged research as well, I have my PhD student write their own critical appraisal of the article. Then they come and present and empower, and they kind of explain line by line, this is what they're looking for, this is what they think the bias is, this is how they figure out what the bias does to the findings and things like that. And then the empower moms do their own critical appraisal. So they develop their own set of questions that they would go through. And then on our website, we kind of put them together like this. Here's one that is more zoomed in, if that's a way to say that. And so first you see the typical epidemiologist view. We're really worried about bias and measurements and all of those things and how things are measured. And so then because of that, we're like, we don't really know what we feel about this, but we have some concerns about what they found based on how they did it, right? But then this is where I think as researchers, we oftentimes forget we put our research out there and we don't know how it's landing with the people it's about. And so I think this line is really important to read, where the moms had come together and said, the study misses perceptions of caregivers and the broader environment of the children. Children's behavior is shaped by many factors. And then one mom commented, this gives me crack baby era vibes, referring to past flawed research that stigmatized families without considering structural and social factors. The crack baby narrative was built on racist, unimproved science that has since been debunked and discredited. What we know now that the real harm came from not just the prenatal substance use alone, but from how we responded. And this article makes us worry about that. As a researcher, if I made somebody feel that way about my science, I would want to know, and I would want to change the way that I talked about the work. And so we also don't just write bad things. And so we have some articles where this is amazing too. So we try to manage that and not be, like the cops of research out in the world. And then digital storytelling. And so the moms really wanted to figure out how to tell their stories. And so I had a little bit of money, not enough money to pay for all of them to do it, but I had enough money to pay for 3 moms. So they went through this month-long personalized workshop. So it was a private workshop with Story Collaborative. And this is where they learned how to take one powerful story, create a script, and then create the video. So they learned how to make their videos, voiceover, stop animation, all with a really cheap app. So they could do it on their phone. And so instead of them telling Story Center their experiences and having Story Center videotape them, Story Center taught them how to make their own videos. And now they can make as many as they want. And then they can also train other people how to do it. So all of us didn't have to go through the training. Um, Another part, and this is largely due this project, I should have a credit here, but it's through a Corey Capacity Building Award. The mom said, we really, really, really want to do research. We want to collect and analyze the data. And so after a couple of meetings, I was like, well, what kind of data do you want to collect and how do you want to analyze it? And there was a huge interest in qualitative data. I'm an epidemiologist and I had not been trained in qualitative data techniques. I started to kind of play around with it a little bit when I was a postdoc. And so we learned together. And so we brought somebody who was an expert in qualitative data, one of the moms from Empower, and then myself. And we spent a whole year creating these modules of how to collect, analyze, and disseminate qualitative data. 19 of the 20 moms completed this training. It took about 8 months. And as a note too, for all the work they do with Empower, they always get paid at least $50 an hour. So I always like to add that in, that's important. This training module is available for free on my website, as well as a lot of materials that you can download and edit it for your own project. You don't have to tell me you're using it. We really want more people to know how to do research. So let me know if you have any questions about finding that. So in the meantime, while doing all this capacity building, we're also collecting data and learning from each other. So we did another kind of story map session, but this time it was as a focus group instead of multiple individuals. So we had 6 of us together, and I asked the question, we have the CDC data that we published. It said people who use drugs are 50% less likely than their non-drug using peers to get prenatal care. What is happening here? And so through that group, the main points came, the red trauma points, trauma points. I see trauma and I see red, but they're not all trauma points, but could be. Right. These are all the things that we kind of talk about related to trying to get into care. I think something really important that came out of that meeting was one of the moms said, I grew up and it was never safe for me to ask for help. Like it wasn't safe for me to ask for help to get to school or for somebody to like help me get a dish. And now that I'm pregnant and doing something incredibly illegal, it does not feel safe even to walk to that door. And then they talked about a lot of things that we talk about, not just with pregnant people. Navigating the system was really hard. It's really hard to find a provider who knows about both substance use and pregnancy. Is usually one or the other. And they feel like they have all of these like one size fits all treatment plans and they feel like they're set up to fail. And so in the green boxes, I talked about different ways that we can address these. And again, happy to share this map, but due to time, I'm not going to spend a ton of time on it. But this map has been really helpful when I go out into the community and work with different folks who may have some kind of power over resources available or healthcare teams, because oftentimes they do not want to see my statistics. People prefer these to that, which I do too as well. But something I really want to point out, like in that map, so you can see it here, but then closer is stigma. And so this is kind of the elephant in the room in a lot of conversations is as they were talking, the artist is like, Nichole, everything we were talking about here is stigma, and I can't just draw a blob and write stigma because otherwise you shouldn't need to pay me to do this. And so we decided to put a cloud and show that it really pervades every step of the journey. So now I'm going to give myself take a drink, and I want you to be able to meet one of the Empower moms and to be able to see what does this look like from the patient's point of view. And if you remember a moment ago, I was telling you about digital storytelling, and then this is one of the videos that they created. Hopefully, you're following along with me. This video won't play within the PowerPoint today, so I have to pull up my web browser. Can somebody let me know if you can see my web browser with the video?
We can see it.
Yes. Thank you. Okay.
Yes, we can see it.
Thank you. I'm going to hit play.
Have you ever been to prison? Do you have custody of your other child? I was so severely dehydrated, I cannot even stand on my own. I spent a large part of this pregnancy very sick. I would vomit profusely throughout the day and night. I lay curled up on the bathroom floor for most of my pregnancy. I could barely work. I could not eat. I could not keep any liquids down or even my medication. I would get these cold fits that I would shake uncontrollably and my teeth would chatter. My husband would throw 4 blankets on me and on this particular day said, "This is enough, you have to go in." I said to him, "I don't want to go. We already know what's going to happen." My husband finally found the courage to take me to the emergency room. "What medication are you on?" asked the intake nurse. My eyes slowly gaze down. I know what's about to happen. Methadone. My OB told me to come here immediately. I was interrupted by a hard sigh. "Well, we can't give you that here." "That's not what I'm here for." The nurse scoffs. "Wait here." I'm wheeled into a tiny corner of the ER. I wait hours for anyone to approach me. The tiny corner where I'm waiting in my wheelchair almost makes me feel safe. At least there's no judgment there. I muster up enough courage to ask for a plastic bag so I don't get sick on the floor. I hear the nurse say to the other nurse, "She just wants methadone." I lower my head, feeling unheard, like they think I'm lying. And I screamed in my mind, "But I'm not here for that." After another hour, a doctor approaches me. "Have you ever been to prison? Do you have custody of your other child?" At this point, my patience is wearing thin. and I've had enough. What do these questions have anything to do with me wanting an ID of liquids? My OB has stated I am extremely dehydrated with a very high ketone level. It was her suggestion I come in. Taken aback that I question him, he tells me, these are the standard questions we ask everyone. These are not the standard questions. These are biases, judgments, and stigma peering through. I walked out of the hospital. This is the last time I will not be heard.
All right, so that is her story, and it just kind of shows how stigma is showing up, particularly for a pregnant person. And as we often talk about why aren't they getting prenatal care, what's happening here, what we're missing is their experiences they've had outside of the OB family medicine setting. They've been treated badly in this institution, so the likelihood of coming back is definitely lower. Let me switch back to my slides. Uh, Switch. There we go. So let me know if you don't see a slide that says, what are we doing about it? I think
We
you
see
can.
it.
Perfect. And so really what we're doing about it. So if you were to come to, Earth or even the United States and you wanted to know that what people were doing about stigma, you would assume that stigma is very closely related to language. And you are right. And so like when you Google it, you'll see all of these language matter guides. I hope that because of who this audience is, you've seen at least one of these, but they all kind of say this word, not this word. Sometimes they will have, reasons why. And they have this really nice recovery dialects one where it kind of talks about by context. But generally, it's this one size fits all approach, other than this dialects one that is my favorite one out of all of them that I have found online. So after the moms have gone through all of this training with me, and I then came to the University of Iowa, and part of my startup package, I had money for a pilot study. So I told the moms, I want the money that I got for a pilot study to be used to fund your research. This is the only way I can figure out how to fund your research, and let's work together and do this way. So we had all these brainstorming sessions. And one of the moms said something that has really changed the way I think about things. I really like the focus on reducing stigma through language, but who got to choose the replacement language? Because there are replacement words that I don't like. And I said, well, obviously, since we have all these language guides out there, there is some science behind the words. And so I'm going to go find that science and I'm going to tell you who did choose the replacement language. And today it's really, really unclear. I'm really hoping that I'll give one of these talks and somebody will say, Nichole, you missed this. This is who it was, because you have all of these articles and papers, but I don't really know why. And this mom is like, why is this word better than the other? I don't really see that. And then we realized in the literature there hasn't been a lot of research done on what language people prefer. There is a huge increase in studies looking at where people are using the words we're not supposed to say. But there's very, very few research studies that have looked to see if actually what is the language that people care about. And so for the first study that the Empower Moms really had a huge piece of in designing the survey instruments and all of that, this is what we focused on. So we really wanted to see what words do persons with a history of substance use and pregnancy prefer? What do they not like? We're not going to go into detail of the final 2 points below just for time, but I am happy to talk about them. And those papers also will be coming out hopefully in the next couple of months as well, but happy to share if you're interested in those points. So who is in our study? So we had 190 people who we did not think were bots. Long story of how we filtered out the bots. And on average age, they were almost 33. It was not a very diverse population. We had about 70% self-identified as white, 72.5% identified themselves as heterosexual. And then in terms of substances used, this really gave us a headache because we asked folks to tell us what substances have you had problems with or use disorders, and they could click them all. And there were so many different groups. And we didn't want to just have one, two, three polysubstance use. We really wanted to get close to this because we hypothesized that the type of substance you used would predict your language preference. So just as an example of the data, so we recruited people out of an online social media support group that's actually ran by one of the Empower Moms that has over 4,000 individuals in it, where it's kind of like peer support mutual aid, where they share with each other advice related to pregnancy and substance use. She started it about 10 years ago when she felt like she had nowhere to go, and it's just gotten huge, which is really cool. And then we use Red Cap. And so this is just an example. We asked people, if you had, how would you feel if a healthcare provider, when they're talking about you or writing about you, how would you feel if they use this word, right? And they could slide it all the way to dislike, and they would get a 0 score, or they could slide it to like, and they would get 100 score. And it was set up where they actually had to move the slider, so that way nobody would just do neutral throughout. And then the data, to be honest, like I've really struggled with looking at it because it didn't have a clear signal right away. It took me a really long time to think about how to look at all this data and then to how to display it because we asked about 61 different words. We have all these groups. So here what you'll see are the top 10 words that are preferred, so liked by people with substance use. The first column are all the respondents together, and then the rest of the columns are the different substance use categories. And then you can see if a p-value is in red, that means that their mean score is different than the other groups. And so the darker the green, the more they like it. And so you can see there is some agreement on how much they like it, but also some differences too, particularly for Matt. And Matt's a really interesting one. I'm just going to pull this one out here. So our language matter guides tell us, do not say Matt. This is why we should not say Matt. However, with the advent of everybody using LLMs now and AI and looking through clinical notes, they will say this person's been stigmatized if these stigmatizing words have been in their chart. And Matt is a really large driver of that. And so in terms of our data, people who overall, and then specifically people who've used opioids, really like it. For some, it was their best word. They rated it the highest. The people who didn't rate it as well is, as you can see, are people who aren't using opioids. They haven't had maybe a positive experience with Matt. It's less familiar to them. They're not going to say, they're kind of closer to neutral, but the people where Matt has been part of their lives, this is a word that they prefer. And so we thought that was really interesting. Similar thing here is that we looked at ratings with the lowest rated terms. So same thing, lowest rated terms are on the left, and then the darker the red, the more dislike that we have. And then with the p-values are red, that is where they are significantly different from each other. I think something's interesting because I think a lot about pregnant folks is bad parent. And so the people who hated it the most are people who tend to use substances that might lead to a removal, right? So they don't, I mean, the people with like cannabis and legal drug use don't really like it. They're still peach, but they're not like in mean score 7. So they do like it a lot more. So lots of things to kind of think through here of how to make some conclusions from this. This slide is busy, and that's busy on purpose to give you a headache because this is a headache that I've had for a while. I wanted to show you why the one size fits all approach doesn't fit. So you'll see all of the words in our data set of 60 that had the greatest discordance, so difference between substance use groups. Every dot is a substance use category, and as you can see, the scatter represents the difference, and this slide is organized by the most differences. So Matt on top again, and this one has the most variation and how people rated them. And then dirty, well, it had a lot of variation compared to the other words not here. Out of all of these words, it has a little bit less variation. And so this just is another way that I've been staring at these data to figure out what it means. I am going to go on to the final part. If any of the hosts think that I'm close to time, please let me know because I forgot to start my stopwatch. So I have about 3 more minutes. If you're worried that I'm going too long. So another part of the work that I did, I mentioned that people are using LLMs and AI to look within notes. And so oftentimes now when I'm reading these papers of folks that have used LLMs, they are basing their LLM model, their AI model, or even if you don't understand the AI part, the keywords they're looking for is coming from those words matter lists. And hopefully I just showed you that it's not all cut and dry of what word is good and bad. And so I've been trying to develop a data set that would be a training data set for a future large language model that has been trained by people with substance use, so from their perspective. And so one of the steps towards this is reading ad nauseum sometimes clinical notes. So these are clinical notes from my institution written about people who are pregnant at the time and have a documented substance use disorder. Then I sat with the Empower moms and I said, what do you think about this? And I'm just going to like old school highlight stuff and take notes. And so with this one, it's related to somebody going to the emergency room. The emergency room staff do not believe they're taking this medication that they reported. And so when the moms were reading through this, they really honed in on unreliable reporters. And so they did have a swear word here. Sometimes I leave the F word in this one, but I don't know this group very well, so I don't know how you feel about it. But they said we're all liars. And then it was really interesting here at the end. They said, we don't believe this person that they're taking this medication. And one of the moms said, they drug test us for drugs all the time. Why couldn't they do confirmatory testing for her meds to prevent withdrawal? And I don't know, I don't work in an emergency room, but I think it's a really interesting question to think about. Another one is related to tubal ligation, and this conversation has spurred another study that I have. I'm going to try to lift off, hopefully by August. So in this note here, the doctor is writing the patient declined to sign their papers today for the tubal ligation because she said she's not certain, but did report to her that it doesn't require her to have it. And I did tell her she's a great candidate because she has a low BMI. And this we spent probably about 90 minutes talking about, and all of a sudden it brought out all of these stories that I hadn't heard from Empower Moms where they feel like there is this push not to have babies again, and they feel like the healthcare system wants to make sure people like them never have babies. And so the research question that the Empower Moms have that I'm trying to work through, trying to figure out how to make it work, is they want to see, are there more conversations related to tubal ligation for people with substance use than matched peers that don't use drugs. Because they asked me if I could figure it out right away. I'm like, nope, that's a whole study, and maybe that's study number two. And the other one is a mixed bag. Here you can see in green, the moms really liked things that were said related to quitting and following up and coming back, even if you use drugs. They said this is a really great way to make somebody feel welcome. And remember, patients can read their notes now, so this is good that they would see that afterwards. But then it's related to the testing, and it's, talking through why do they need to test this person so often? And so they already self-identified that they use drugs. They've already had a drug urine screen that has shown what drugs they use. But here it says plan for the test at all OB visits and fetal cord blood. And so something that the moms in Empower have said oftentimes is during pregnancy, we're a group of people where we really need to feel nurtured. However, we just feel like we're tested over and over again. And I think this is a really good example of that. This is the last slide, by the way, and it is the best one I could find. And so the mom said, and I de-identified the note so I wouldn't glare at physicians in the hall. So I don't know who wrote it, but they want this physician to be thanked. They said, by reading this note, we can see there's true advocate. And the reason why they felt this way is that physician took the time to talk to them about the risk of neonatal withdrawal and told them what the signs and symptoms are. And then the other part is related to pain management. They said, this person really wanted to make sure the note said that this person definitely can have an epidural. It's recommended. It does not interfere with their Suboxone. And this is just related to, I think this clinician has probably seen, there's a lot of misunderstandings about how to handle pain with people with substance use, particularly opioid use, around the timing of delivery. And so the patient said just by this writing that they knew this was like a good person. So I think it's also good to show some of those good pieces. But at the end, in a summary, hopefully I've showed you a little bit today that research done with patients, I think, is more meaningful. It's more meaningful for me. It's really changed the research questions that I ask. We know that language is not neutral, but we also need to think maybe beyond just a one-size-fits-all approach. And so this is something I'm thinking about how to address. Know that capacity building takes a long time. So I started with these moms in 2019. So this is like a whole my career, because that's when I started mine after grad school, of the work that I've done. And really, patients are experts in their own care, and we need to have them included in everything if we're going to design programs that work for them. And with that, I can take your questions. Hopefully I didn't go too fast.
Thank you, Dr. Nidey. Thank you. And we're opening the floor right now for our participants. Please feel free to add your questions in our Q&A chat. But also, if you have any comments, you may also use the regular chat to add comments or resources that you think are relevant to the topic. And I'm coming back on camera right now. All right, so we have someone here who says, thank you for sharing that testimonial and helping provide context around the lived experiences of women seeking care. It was powerful to hear how stigma and judgment can affect someone's willingness to reach out for help. Given the power dynamics that can be present in these interactions, what phrases, communication strategies, or replacement language would, I'm sorry, I move for a moment here. Um, do strategies or replacement language? I'm sorry, I missed the chat for a moment. Would you recommend, which strategies would you recommend to help individuals advocate for themselves, express concerns, and navigate certain situations? That's for you, Dr. Nidey.
Sure. Yeah, no, that's a really good question. And thank you for all of the nice things that you've said. I think that's tricky, right? This is something that I'm sitting with right now with some of the qualitative data related to language. Like people in qualitative data says, I want to be called a drug addict because really that's all that I am. And so when you think about internal stigma, what is the role of the healthcare provider to say, well, actually, like I don't see you this way, right? These are ways I see you as a really great mother. I think you're really good. You brought cookies in. You're like all of these things, right? Like I see you beyond just that. And so I do think that there is more research. This is just like the pilot data of this to see what situations do we call people what they say they want to be called if we think that's causing harm. And then I get worried about some of the paternalistic pieces of that as well. And so that's ripe for research. But I think something that I think is a little bit easier to do as you kind of think through is to tell a patient or community member, whatever role you're in, is, there's a lot of different words people use to describe somebody who has like an opioid use disorder. Like, what word do you like? And then if you can't remember it, because you have a lot of people you talk to, write it down in their file, like they prefer this word. And then if they say a word that you've seen or you feel causes more internal stigma, to say, oh, usually I say this word because I worry about this. Like, what do you think about that? I mean, I think there's a lot of different ways to open those questions up. But I think first starting with what do you prefer and why? And then how to, if we feel like we need to move to a different spot, that's another research question to think about where that's appropriate.
Thank you. And then we have another question here. Someone is asking, have you had the opportunity to share these results with perinatal providers? If so, what reactions did you receive?
Yeah, so these results you just saw here, they have not explicitly been shown just to perinatal providers. They are actually being presented by one of my grad students in Portland this upcoming week. But a different story, I mean, a different project related to stigma and discrimination. I collected data just of perinatal patients from a very specific clinic. We showed there's a lot of experiences of stigma, and I was able to quantify the relationship between stigma and overdose and return to use. And so they brought me in to do a training with their providers for a day. So I came in, they shut their clinic down. And so it worked really well. I was a postdoc at the time and I was terrified that I had to tell this mentor person that their clinic has these bad results. But so I have shared, and I share at a lot of academic meetings too. And I go to any meeting that involves people who care for pregnant folks, because if you care for pregnant folks, you will for sure eventually care for somebody who uses drugs.
Thank you. And I also have a question for you, Dr. Nidey. From the point of view of a researcher, of someone who does research and who's actually involved with pregnant women who use substances, how do you see the evolution of stigma for women, pregnant women who use substances? Is it getting any better? Is it improving? Why?
Yeah, I think that's a really good question. I think it's context specific and institution specific and things like that. But I would say overall, I think it's getting better. Um, One of the moms in Empower was talking about stigma the other day, and she said things are getting better at a glacier's pace. So sometimes if you don't pay attention, you won't notice the positive changes. So you sometimes have to look for it. I do think it's getting better. I think there's more just, like we have a easier time talking about mental health now. And there's been a big push to include substance use in that umbrella. And so that acceptance is there. What's really tricky though is pregnancy. So even like within substance use communities, we've seen some qualitative data where everything is kind of okay until you're pregnant, and then you see that stigma being layered on because you're a pregnant folks. You're a pregnant person. And so I had a thought the other day. I think I don't know, I'm going to say it. It's my opinion based on the disclosures. I've had no time to look it up. And if anybody's interested in thinking about this together, is it's been really interesting to see the evolution of the GLPs. And now I feel like there's so many people I know who are using a GLP, and before nobody was talking about it. And now people are talking about it. And now they're talking about like how it takes away the cravings. And I'm like, we have normalized something to take away cravings. Could that have a positive effect on the way society looks at like medication for opioid use disorder? I hope so, but I think would be an interesting question.
I think it's a great point because it's a medication that
Hmm.
so many uses, and because it has become so prevalent and so
Yep.
popular, maybe that help all of us to see medications for substance use
Yep.
disorders under a completely different light. Because the
Yeah.
medication, although there's plenty of research to go, but clearly it is a medication that
Yep.
definitely, hopefully, could help with substance use disorders as well. And I see another question here. It says, what strategies have been most effective in building trust and encouraging authentic participation in substance use disorder treatment among pregnant and postpartum women, particularly when they have concerns about stigma, child welfare involvement, uh, or legal consequences?
Yeah, there's a couple different answers depending on the context. So in terms of Empower Moms, like I said, a lot of us have been together since 2019. And so everybody says show up, but like they don't really talk about how, right? And so I talked a little bit about this in the capacity building thing is they know that me as a researcher, I have certain things that I need to do to check my boxes to, you know, climb those steps and keep a job, right? But then they also had all of these ideas for things. We were talking about developing a book list for people in prison, right? This has nothing, like it has everything to do, but also nothing to do with my job. And so it doesn't matter what they propose, is I spend as much time responding to their interests as they do to the research piece. And so you have that full partnership. And then I also write them in grants. I don't write them in just as like stipend for a person with lived experience. They're written in as a consultant or a co-I, depending on the model structure. And so they have true leadership. Even if we don't get the grants, especially right now, they see the budget and they see the way they're written about that they are a leader, not just an add-on. And that's helped a lot too. In terms of research, I've been really careful when I get people to participate in my study, is I never ask people to disclose substance use during pregnancy. It's not the best method in terms of bias and like thinking back in time to what happened, but I'm asking them to think back at a time of something that already happened and the risk of incarceration, CPS is gone. And so I have given up like the gold standard for methods and research more so to make sure that it's safer for the moms to freely talk about experiences in the past.
Thank you. And we have another question here. Could you speak more about the roles that peer support specialists, community health workers, and other non-medical members of the care team play in supporting women and families?
They do everything. They're amazing. And so we had a project, I didn't talk about it here, but a majority of the moms in Empower are also trained as peer recovery support specialists, and I was able to finagle that with a grant. So when I was in Ohio, I realized their peer recovery support training curriculum didn't include the word pregnancy one time. And so oddly, when I called and whined about it, they answer the phone, which was my first surprise. And then my second surprise was they're like, well, if you send us a budget, can you fix this? And that was the easiest grant I ever got, is just by whining. And then together, what we did is the moms did the training for peer support as is. And then we spent a year developing an additional part of the curriculum that could be added on for people who work with pregnant folks. But I think I would consider people with lived experience the most important person on any team, and I see them as more of like the bookends, right? They should be in the front of like having people come in. This is a safe place for you. this is, what my experience was here. We do that in the clinics that I work with here. And then at the end too, like, did you get everything you need? When I was using drugs, like this type of thing was important to me to have that because a provider, despite their best efforts, they're not going to know that if they don't have that experience. So I think it's important that they are greeting on the way in and on the way out. And I think all clinics need one.
Wonderful. Someone is asking, is introducing this material into medical school's curricula a goal, and can it possibly change the landscape of how providers approach pregnant mothers in recovery? That's a good question.
Yeah, that is a goal. We just submitted a grant to develop like a curriculum and do a trial based on the curriculum. But I spent a lot of time giving guest lectures in our med school. You can't see it, but I'm pointing. You can't see my big window, but I'm looking at the med school. So I go over there all of the time. And give lectures, but they do not talk about substance use in general enough in med school, let alone pregnancy. And so I have been developing a training program that was co-developed with people with substance use of this is how we need to be cared for. And so long-term goal, hopefully if you invite me back in a year or two, I can talk about that.
All right. And I think we have time for one or two more short questions. Someone is asking, do you have any reports or publications related to this project that you recommend for us to read, including how to design the research, analysis, and the method part?
Yeah, so I am putting my email in the chat. I don't know if it was shared in any other way, but if you send me an email, I can definitely point you to different things, whether it's a research report or a project or a recording that we've done in different places. And so just let me know what you're specifically looking for and where you're coming from. I don't think I put a dot after my UI. I think I messed that up. Unless
Oh,
it
yes.
might look
You
weird.
can
There it is.
retype it.
There you go. I got it for you. Yeah, so you're welcome to email me and you could just put like text TXSUS, however you Texas sus. Is that what you guys say? I don't know. If you put that in my in the line, I'll know and then I can figure out how to share something with you.
Yes. Okay, so I have another question here. Going back to your research around language, would you be able to provide any sites or papers you came across? This is a huge conversation for us right now, and love that you talked about it. It's kind of similar to our previous question.
Yeah. And so we have a quantitative paper and a qualitative paper that are under review. I'm happy to share some slides from those papers. I'm happy to come talk to you about them and just a conversation as well if you're interested. And then also happy to share some of the literature that we found when writing the papers. There's not a lot, but we did find some things. A good hint is in the disability space when they switched to person first and neutral language. There was a very similar, a lot of folks with disabilities have said, I actually don't like this language. And so this idea of going back to asking people what they prefer is not new. It's just, I don't think has been done in this population before. So we had really similar results of what was found around the time of the language shift in the disability space.
Great, and we definitely would love to have you back to talk a little bit more
Happy
about
to come
that.
back.
You have been an amazing speaker, so we will be happy to have you again for that. It looks like we don't have any more questions for the moment, but if any of you would like to add anything, please do it on the chat or on the question box. This has been an amazing presentation, and we want to remind our participants that this great material will be sent to all of you with a post-session survey right after this session. I think we can move to our announcements very quickly. We want to remind you of a couple of events that we have. Okay, so we're going to start with, this is great news for all of us. Be Well Texas Now offers a free perinatal consultation line for providers caring for pregnant and postpartum patients with substance use concerns. Please call 210-450-7693 for expert clinical guidance on treatment options, medication management, co-occurring conditions, and referrals, all at no cost to you or your practice. And next, in collaboration with the Be Well Texas and the Perinatal Psychiatry Access Network, or PeriPAN, our maternal health echo program provides perinatal healthcare providers with training, consultation, and ongoing support to help enhance patient care. This echo meets on the first Tuesday of every month at noon, and we invite you to register and join us for our next session on July 7th. We hope to see you there. So we're sharing with you that link. For some of you who haven't registered to the maternal echo, they can do so by clicking on that link. And next, regarding our CEUs and CMEs, medical behavioral health and peer professionals are eligible to receive one complimentary continuing education credit. To claim your credit, please complete the post-session survey. We're dropping the post-session survey there. Please remember to answer yes to the question regarding CEUs, and in approximately 3 weeks, you should be receiving your certificates via email. And for CMEs, we'll send you instructions in an email after this class. And I want to thank you again, Dr. Nidey. This has been an amazing presentation. Thank you, thank you. We definitely would love to have you back. And to all of you, thank you. And I want to remind all of you that the Texas Substance Use Symposium is coming. So please be on the lookout. We're going to be sending some communications with dates and more information. Thank you to all of you. This has been a great session, and have a wonderful rest of your day.